Okay, everybody, so I have 2 o'clock. So good afternoon. I'd like to welcome everyone to the last Falls Community Session 2016. It really hurts me to say that right now, knowing that tomorrow's December. So my name's Evo McDonald, and I'm the Long-Term Care Best Practice Coordinator working in the boundaries of the Champlain-Lynn. Both Amy Reed and Frida Poirier and myself, as the co-leads of the Falls Community of Practice, would like to thank you for joining us today. And I'm very pleased to have Eric Heinemann with us today as our guest speaker, and I'll introduce him a little bit more formally soon. So before we begin, just some quick WebEx basics. So the phone lines have been muted. They're going to be unmuted at the end for questions. If you do have any questions throughout, please type it in either the chat or the question and answer box that's located on the right-hand side column of your screen. It will be monitored throughout, so any questions you have for Eric or during the presentation or any technical difficulties, please type it in there. If you'd like to expand the screen, the little double arrow in the right-hand corner of the little WebEx screen will expand it for you as well. And just note that this session is being recorded. So I'd like to welcome Eric Heinemann. He's a kinesiologist with NeuroGym for the last 11 years. He's an outpatient physiotherapist, it's an outpatient physiotherapist in Ottawa. He's the director of NeuroGym Fit Division, which stands for Functional Independence Training. Eric consults with long-term care homes and convalescent facilities across the province. He teaches in the Faculty of Health Sciences at the University of Ottawa, and his master's focused on falls prevention and mobility in the elderly. So we're really pleased to have him here with us today as an expert speaker. So welcome, Eric, and thank you for joining us.
Thank you. Great to be here.
So there are 3 objectives for the presentation today related to functional mobility. The first is to understand why it's so important, then to explain some of the tests that are available to assess functional mobility, and finally we'll use a case study method to demonstrate how we can quickly apply this on. So just to bring us back again to the algorithm, so we've covered off the falls risk screening, we've talked about assessment tools, and now we're going to be focusing on functional mobility, ambulatory versus non-ambulatory. It's very sensitive. All right. So, I think this is you now, is it not?
Yes.
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 Okay.
Thank you, Evo, and good afternoon, everybody. So I'm going to talk a little bit about mobility in the context of long-term care and also in the context of falls. And falls and mobility, as I'll try and make the point as we go through the presentation, are a little bit of a balancing act. And for a long time, falls have been a focus in long-term care and in many other environments related to senior care. And I think more now we're starting to recognize that, yes, we want to prevent falls, but at the same time we want to avoid, if we can, curtailing mobility, because mobility is a very important determinant of health outcome, both in long-term care residents and in the elderly in general. And so I think there's more of a focus now on mobility and the benefits of that in that context of fall prevention. So I'll talk a little bit more about mobility as we go through the presentation today. So we do know it's built into the MDS system that changes in mobility do have far-reaching impacts on health status. So just for example, from the MDS structure, we know that declining ADLs, particularly the mid-loss items, and the mid-loss ADLs are things related to transfers and locomotion. And so when a resident declines in these sort of key mid-loss functions, there are potentially some negative health outcomes that are associated with that. So again, as somebody's transfer status declines or as their ability to walk or move around declines, that person is not only just going to be at higher fall risk, but there will be implications for continence. Someone who cannot transfer to a toilet can become functionally incontinent, so that just the act of getting onto the toilet or walking to the bathroom becomes difficult. A person that has difficulty transferring or moving around is generally moving less during the day. Their pressure ulcer risk increases. And declining mobility does have impacts on cognition and mood. So beyond the physiological, so when we're not moving as well, there are physiological effects that affect our mental function, but also in terms of if we're not moving well, it's difficult to participate in social activities, difficult to get out of the room. So all of those things, again, coming back from these mid-loss type skills are associated with some fairly significant far-reaching health consequences. So this is sort of the importance of mobility. And just to, I guess, highlight that point, I'll take you through a little bit of a facility type case parable, I guess, if you will, because there's a moral to it. So this is a story of kind of two facilities that I worked with. One in particular I work closely with. As Ivo mentioned, I do consulting to long-term care facilities where we help them with developing sort of progressive mobility training programs. So I'll work with a physiotherapy provider, restorative care within the facility to help them in the way that that I work as NeuroGym to kind of develop mobility training programs for the residents. So we'll look at kind of tracking two facilities. These facilities were similar-sized facilities managed by the same chain. They're both in the GTA. Facility 1, the facility we'll see in blue, is the program that I worked with. We designed a mobility training program delivered by their physio and restorative staff that targeted these mid-loss ADL items, so transfers and locomotion. And we worked this facility for what we see on the graph here a little over a year, and contrast that with another facility. This is facility 2 that we'll see in red, and we're going to look at the results of these two facilities, so one with the mobility training program, the other one without. Now if we just look at falls, taking that kind of narrow focus on falls, the facility with the mobility training program, they actually saw a modest increase in falls over a year. So they were sitting at around 13% when we came in and started working with them. Their falls did increase about 1%, almost 2% over the course of the year we're working with them. By contrast, the facility that didn't have the mobility training program, their falls plummeted. They seemed to be doing a smashing job in terms of fall prevention, and I had a lot of explaining to do in terms of the mobility program for why it looked the way that it does. Why it did look the way that it does, again, falls is not necessarily the only item we want to focus on in this kind of context of balancing mobility and fall prevention. So if we shift to the next slide, so up in the top here, there's that fall data. So again, the facility that we worked with had that modest increase in falls, while facility 2 that didn't have the mobility program, they actually hit a provincial benchmark in terms of falls and seemed to be doing really well. But when we shift to other indicators, a different story starts to emerge. So moving to the lower graph, facility 2, that's the facility that didn't have the mobility training program. If we think about what's going on with their worsened ADL scores, so that percentage of residents whose ADLs, and again those mid-loss items are in there, have worsened in the last quarter, we see that it starts to rise in that facility. Whereas in the facility that does have the mobility training program, those worsened ADL numbers really start to drop off fairly quickly. So they actually hit provincial benchmark about a year into the program in terms of their worsened ADL scores. So people are not declining in terms of their ADL function. They're staying more mobile, and this does present more opportunities to fall, and this is what we see in that kind of small increase in the number of falls. But again, we're keeping more residents at a higher level of function through this program. And as I mentioned earlier, so if we're able to preserve function, again, we can affect some of those sort of far-reaching health outcomes. And we can look at that as if that's not addressed, so if residents continue to worsen in their ADLs, yes, they'll fall less. People who don't move don't fall, but there are a lot of other problems associated with that. So if we shift to the next set of graphs.
Little arrow.
If we look farther down the road at pressure ulcers, so again, the facility with the mobility training program that saw the modest increase in falls, steep decline in worsened ADLs, and a slight decline in pressure ulcers where they're sitting, quite low below the provincial benchmark. Whereas the facility without that mobility training program, yes, fewer residents fell, but those residents continued to worsen in their ADL performance, and farther down the road, we start to see a rise in pressure ulcers. So again, this idea of balancing, when we want to look at falls prevention, we want to balance that with promoting mobility. And we know, and certainly the research has started to focus a little bit more in the last couple of years of the benefits of mobility training, and we want to weigh that against fall prevention strategy. So to that end, again, limiting mobility does offer us short-term safety. So residents, again, who don't move won't fall. If we go to 100% restraints, you can go to 0% falls, but nobody wants to do that. The long-term consequences, again, residents who don't move are going to have worse outcomes in other areas over time. So our challenge is really to try and encourage mobility to try and get those beneficial aspects of health farther down the road, but at the same time be mindful of resident safety, so the fall prevention piece again. And the way that we do that or meet that challenge is to structure the kinds of environments and activities that maximize safe mobility. So we want to create experiences for residents that allow them to move in the way that they can, but at the same time promote moving in a safe way, so in a safe context. So we want to get our residents to be as mobile as they possibly can while still creating the right amount of. And to do this, we need comprehensive evidence-based assessment tools to try and determine how to safely encourage mobility.
So depending on the structure of your home, the physiotherapist may or may not be available to do a functional mobility assessment right at the time of admission. So therefore, it comes down to the roles and responsibilities of registered staff. And so there's several important areas that need to be addressed on admission. So the first is a basic functional mobility assessment to be completed. So this is so that you can understand their transfer status. It allows for you to plan the type of care that this resident may need. So for example, when you're doing morning care, there's sort of two ways of doing morning care. You're either going to provide care in bed, which could be limiting to the resident's mobility, and you could see declines, or the other is to take them to the bathroom and do their care while they're on the toilet. But that poses some risks and challenges because you have to stand this resident at some point in order to do pericare, to pull up their pants, and so they need to be able to have the strength in order to be able to stand. So if you have no idea what type of functional capabilities the resident has, it puts the resident in danger as well as staff. So the other piece that needs to happen too is, what Eric was talking about, so having this understanding of what the resident can and cannot do so you're not aiding in decline. So the second thing is that registered staff need to be able to communicate functional status to all staff and to develop the mechanisms of communicating with physiotherapists about residents' functional status. So the role of the physiotherapist then is to help validate the assessments that the registered staff complete, do more in-depth assessments in terms of mobility and strength, and make recommendations. So there's this real need for effective communication channels between the physio department, nursing staff, and PSWs.
Yeah. Okay. So within that structure, I think we're missing a box there. But going back to our flow diagram, several slides back, there it is. So one of the ways we can kind of stratify how we look at this simplified resident assessment is just broadly looking at ambulatory versus non-ambulatory. And within those categories, there's an abundance of different types of tests that are available for use by physiotherapists or, for anybody doing a mobility assessment. We've highlighted a few of them for the purposes of this webinar that Ivo has researched and will provide in a couple of slides some web links that you can look at. But the ones that we'll mention here are generally tests that have been validated in the long-term care context and can give you kind of a good starting point for assessing residents that are either ambulatory or non-ambulatory. So these kinds of tools can help with decision-making in the short term around what kind of care is going to be safe and appropriate. And also it gives us a starting point for knowing where we can safely mobilize, again, to provide that piece of preventing functional decline. So if we switch to the next slide, here's a nice set for those various tools of areas where you can find not only the scale, but also a YouTube video for how to actually run through the test. So that's a fantastic resource. Thanks for pulling all that together, Ibo. So that's in the slideshow as well. This is the function in sitting test as well for non-ambulatory residents, and this gives an indication, as we'll see in some of the case examples, where we can look at bed mobility and balance in sitting. And again, the purpose of the tests that will be tests that can be used by registered staff or by physiotherapists gives you that kind of initial assessment of the resident to start to figure out what level of care is going to be early on appropriate, so that we're both promoting mobility and not unnecessarily limiting it, but also doing that in a safe context. Okay, so the next thing we're going to do is take a look at an example of kind of a functional mobility assessment algorithm, so a simple way that we can start to stratify residents into ambulatory versus non-ambulatory categories, and then use that as a jumping off point for employing some of these more specific tools. And the algorithm that I'm going to show you comes from an initiative called the Mobilization of Vulnerable Elders. The Ontario branch of that is called Move On. So it's something that was started, I believe, at the University of Alberta and has been carried into Ontario. And has been developed in a number of hospitals and facilities here. And the Move On has created kind of a simplified mobilization assessment algorithm that is, again, achieving these purposes of promoting early mobilization in order to prevent functional decline. So again, not just a fall risk stratification, but something that creates safety but also promotes mobility. So it gives you a way to, again, assess mobility with an eye toward designing a plan of care. And again, we're designing that plan of care to promote as much as possible mobility, but doing it safely. So we'll take a look at that. And so the algorithm starts with sort of 7 kind of hierarchical questions that you can use to initially categorize a resident. Starting at the bottom there with number 1, so can the resident respond to verbal stimuli? And then moving again to progressively higher levels of mobility. Are they able to roll from side to side? So looking at trunk strength and the ability to sit up. Can they sit at the edge of the bed? So starting to assess balance and equilibrium. Are they able to straighten one or both legs? So now we're checking the integrity of the legs for weight bearing. Then can they stand? If they're able to stand, can they shift weight to one foot in order to take a step and make a transfer to a chair? If they're able to do that, can they walk a short distance? So this kind of hierarchy of mobility skills is tested progressively in this 7-step algorithm. And based on where the resident gets to, they're assigned to one of 3 different levels. So ambulatory or level A, if they're able to walk a short distance. If they can stand and potentially transfer, chair level B. Or if they're not able to stand and are able or not to sit or roll in bed, they're classified as mechanical lift or level C. So these kind of 3 categories that come from the 7-step approach can give us sort of our initial starting point for assessing residents for mobilization in part of their care plan. And again, you may or may not need to take all of the 7 steps. So if you encounter a resident asleep in their bed, you may have to start from step 1 in assessing them. If you meet the resident at the nursing station and they've clearly walked all the way down there, you can kind of skip some of the other steps and you know where you're starting from. Now, once a resident kind of is classified according to one of these 3 mobility categories, within that, so within, let's say, the ambulatory level A, this is where you can start to employ some of the more specific tests. So things like the Berg Balance Scale, the Tinetti instrument, or the Timed Up and Go can help you look at a resident within level A and find out what are some of their strengths and weaknesses in terms of their standing and balance abilities. And this, again, can help you formulate a plan of care. And we'll look at that in some of the case examples in a couple of minutes. Within chair level B, so somebody that is able to stand but not walk, we can use things like the Timed Up and Go test and the 5-time sit to stand test to start to evaluate that person's standing ability, again with an eye toward planning a care situation. Or within the level C, we can use the function and sitting tests, again, to determine what level of care is going to be appropriate in terms of safety, but also allowing as much mobility as we can. And again, the goal of doing all of that and building mobility into the care plan is to develop kind of an individualized care plan that allows the resident to be as mobile as they are currently able to be, and that we're not kind of unnecessarily limiting resident mobility. So let's take a look at a few examples from these various ambulatory levels and how we might go about using some of these tools. So example resident 1, this is someone who is able to walk independently. They own a four-wheeled walker, but they don't always use it. So this might be the person that has a walker in their room, but you may see them moving across their room, holding on to furniture or taking a few steps without any aid. And so this person, again, is a category A, so they're able to ambulate if we go through that sort of 7-step hierarchy question. Now within that, we may want to do some of the more specific tests. So let's say we give that person the timed up and go test, which if you're not familiar with it is rise from a chair, walk 3 meters, turn around, walk back, and sit down. So they're able to complete that, let's say, for example, in 20 seconds, but they stumble during the turn. We may also assess them with the Berg Balance Scale. And let's say our hypothetical person scores 38 out of 56, and we note that they're unsteady during each of the turning items. So what we can get from that in terms of just risk against stratification is that resident should ambulate, but they should have their four-wheeled walker with them at all times for safety. So we may put in that person's care plan they should walk to all of their meals 3 times a day, so they're getting their mobility, but make sure that they're taking their walker with them because we know they're unsteady with direction changes. And that can be put as a big sign, as a reminder to the resident, take your walker wherever you go, or all of the staff can be educated that that particular resident, if they see them without the walker, that they need to have that if they're going anywhere. Further to that, if we were to go kind of a little bit further on into the care plan, and this may be getting out of the scope of the nursing staff and then where things would be handed over perhaps to physiotherapy, if we were to continue with the resident, example resident 1, in their plan of care, let's say they also have difficulty dressing independently because they've got some limited shoulder mobility, so they can't independently put on a shirt. They may trigger a referral again to physio to develop a targeted exercise program to improve shoulder range of motion. And when that exercise program runs its course, then we may want to reevaluate and see if we can change that person's dressing care plan to encourage them to kind of self-perform that task after an intervention. Okay, so high-level example. So if we shift to a second case example, so example resident 2, let's say this person, if we're going through again our 7-step hierarchy, they reach the point that they're able to extend both legs on that score. They're able to stand, but not able to independently make a transfer. So we'd categorize that person as level B, so they can do bed-to-chair transfers with assistance, but not independently. So we may assess that person with the 5-time sit-to-stand test, just to get a better idea. We know that they're able to stand, but it may be beneficial to know more about their standing ability. So the 5-time sit-to-stand is a fairly simple test, just testing how long it takes someone to complete 5 repeated stands. If we do this test on example resident 2 and we find that he can stand 5 times, but it takes him 75 seconds. He needs several breaks, maybe he has to make several attempts to get a number of stands. So we know a little bit more about his standing endurance particularly. And we can kind of judge based on that his standing endurance might not be sufficient for standing care. So it may not be reasonable, even though this person can stand once, it may not be reasonable to expect him to stand for a full minute while we're doing care, pulling up pants, doing pericare, anything like that. So again, the 5-time sit-to-stand test gives us a little bit deeper understanding into that ability, and we can plan appropriately for his care. So we may not want to, again, try and expect that person to stand too long. So it's, again, we're being mindful of kind of staff safety, but trying to promote as much as possible that mobility in the resident. So we want to do standing care, but maybe not expect quite so much. And based on that, we may want to develop a mobility plan for that resident to see if we can do exercise, restorative, or physiotherapy to improve his standing endurance. So let's say we can get that resident to doing the 5-time sit-to-stand test in less than 30 seconds, and then reevaluate his ability to do standing care. So once he gets to that threshold that he can do the sit-to-stand test more consistently, we may want to reevaluate and say, now I do want to expect him to stand for a period of time during care, and continue to promote that mobility. So again, an example of how this kind of assessment can lead us to a care plan that's mindful of safety, but also set goals for improvement and continue to promote mobility. So one more example, our resident 3. So let's say this resident has a stroke, maybe some right side hemiparesis, so weakness in the right leg. Now, when we go through our 7-step algorithm, they get to the point where they're able to straighten. They can straighten their left leg, but when it comes to the right leg, maybe they're missing some range of motion at the knee, so they can't get full knee extension. And when they do try and extend, maybe their ankle turns inward or inverts. So we see that this person is at level C. Their right leg isn't safe for standing. It's not kind of an adequate platform for weight bearing. It may look something like this. So we know that that person, we wouldn't want to expect them to stand for care just because of that affected leg not being suitable for weight bearing. But again, this would lead us to potentially designing a targeted physical activity intervention to get the ankle to a stable position or get the knee to full extension on the right side. That would then support doing standing for care. So again, this leads us to kind of a goal that we can aspire to as far as improving mobility in order to integrate that into the person's care. And if we're going to continue in that vein for resident 3, given that they're not standing at this point, we may also want to consider that eye towards, again, preserving mobility, promoting as much mobility as the resident is able to do. We may want to consider some sort of an intervention to make sure that their trunk and lower extremity strength in a non-weight bearing position is maintained. So we may want to give them some bed mobility exercises or try and expect as much as possible in terms of bed mobility from that person in their daily care, or design exercises, whether it's with a dedicated piece of equipment or some exercises in bed to kind of preserve that function, but also build towards potentially a higher level of mobility in the future. So again, this idea of designing the care plan with safety in mind, but also in a way that's going to mesh with physical activity goals toward that kind of ultimate goal for all the professionals involved of mobilizing that resident as much as possible or promoting that mobility. Okay, so going back, sorry, I skipped ahead there. Into summary, this is again coming back to the MOVE chart. So those categories of mobility is similar to what we've seen before in terms of stratification for fall risk. What the MOVE on program builds on a little bit is for each of these mobility levels, so level A, B, and C, they've also made physical activity recommendations to preserve kind of the resident mobility within that category. So for residents in level A, the goal here under the staff role column is to make sure that that resident ambulates 3 times or more per day. So if somebody is able to ambulate, we want to make sure that they're doing that activity often. For residents in level B, make sure that they're up in their chair 3 times a day, that they get up to move to a commode chair, that they're doing some kind of active range of motion. So if they're able to stand, make sure we're standing them as often as we possibly can in the context of their care. This, by the way, was one of the original MOVE studies looking at residents in that kind of level B. What they were doing initially is with their personal care staff, every time that the resident had to get up to do something, they had the staff have them do as many squats as they possibly could during that period. So every time that they had to transfer, they had to do 10 squats. And they looked at this as an intervention to kind of build up mobility. It was a fantastic study. Slaughter, I believe, is the lead author on that from the University of Alberta. Again, in category C, there are also physical activity recommendations, so it's more difficult for these residents to be active because mobility is limited, but just as important. So again, encouraging residents to be upright for meals, active and passive range of motion, and this may even be doing whatever self-care as part of their care plans that they're able to do, or whatever self-performance they can do in their ADLs, assisting them with turns in bed as necessary, and getting them up to the chair at least once per day. Those are kind of the base recommendations there. But again, the idea behind the Move On recommendations, or at least this set of physical activity recommendations, is to recognize that while we may stratify people for safety for fall risk, we also want to do whatever we can to promote their mobility within that category.
So I hope that everyone now has a greater understanding of why functional mobility for residents is so important for their well-being and quality of life, and in particular that association with fall risk and hopefully prevention. It's important to understand the role of nurses in completing a quick functional assessment in order to make sure that the resident is appropriately classified and we don't have those declines, and then making that link between the physio team, nursing, and nursing rehab. So just a quick reminder for those who haven't linked with their best practice coordinator to link with them and finalize their gap analysis and review your FALS data. As you can see, our next session isn't until January 19th in the new year. So that brings us to the end of the presentation piece, but now we'll open it up for questions. So if you have questions on the phone line, please use *7 or *6 to unmute, and you can ask your question, or you can use the chat box or the question and answer box as well. So I'd like to thank Eric again for doing this presentation, and wondering if there are any questions at this time. So I have one.
Okay.
I know that last time there was some questions about trunk strength.
Yes.
Is there any links between trunk strength and risk of falling, particularly in reaching?
I mean, I don't think I've read anything specifically linking trunk strength to fall risk in somebody that's upright. Trunk strength is going to be important in terms of all upright mobility, so the ability to stand, the ability to walk and step all depend to a certain extent on trunk strength. So it's something you definitely need to have, and I guess it's something that if you're not up and not moving around a lot, it's something that we lose in a hurry. So somebody that sits most of the day that doesn't stand independently, they're going to be losing trunk strength at a pretty alarming rate in a short period of time. So it is something that's often very weak for residents in long-term care, especially the residents who don't move a lot. But it is one of the things that, so again, just having somebody do, let's say, a list opposed to a full mechanical, that person is going to get some trunk work during the context of the day, or somebody that can do, bridging in bed, or that has to try as much as they can to do their roles, with minimal assistance if they can. So it's something that, again, we lose when we're not moving around a lot, so it's something we do have to pay attention to, I would say, as far as promoting mobility and trunk strength. I'm not sure if that...
So like reaching exercises then is particularly important to help try to...
Yeah, but the trunk will really get work in the context of standing and moving. So that's one of the probably most powerful exercises in terms of the most bang for your exercise buck that you can do. Getting somebody standing up is going to work their trunk, so it's going to work trunk extension as they stand up, and that's kind of one of the key features that they're going to need. For example, having somebody sit in their chair and do leg lifts is going to do a little bit for their legs, but getting that person up to standing instead is going to work their legs. It's also going to work their trunk. And when they're in a standing position, they're going to be working on their balance as well. So again, the more functional, I guess, the exercise can be, or the larger the movement can be, you'll start to incorporate all of those elements. So Yes, there are specific trunk exercises you can do in a chair, like sitting forward from your backrest and leaning from side to side. But really, if you can get the person standing, it's going to be a powerful way of training that.
Hi, it's Sally from Glenstone Lodge. Can you hear me?
Yep.
Yeah, we can.
Okay. Just a quick question. I was just wondering, Eric, when you were working with the home in Toronto, obviously there's lots of residents with cognitive impairment.
Yes.
That affects their, well, maybe not their mobility so much, but their ability to remember that their mobility is compromised. So I'm just wondering, when you were having discussions about the increased fall rates, was that taken into consideration?
Yes, that's a great question, and it's a difficult balance as well, cognitive impairment with kind of promoting somebody's mobility. So, to a certain extent, we want to think carefully about, and I think that's, I guess, the point of your question, if you train somebody to be mobile, they're not necessarily mindful of their own safety and can get themselves into trouble. And one of the things as well, I think that we considered when we're designing that program is sometimes people will fall, thinking of the people that get up out of bed that shouldn't necessarily be getting up out of bed on their own. And with some of the facilities, we kind of addressed that in a number of people. So they had residents who would get up out of bed when, they shouldn't be, and then they would fall over. And what we would do with some of those residents is we'd actually train their standing ability so they got out of bed, but instead of falling down right away, they could stand up long enough that when their bed alarm went off, staff had time to get to them before, it resulted in a fall. So that's just a couple of examples there. In those instances that it did happen, the resident was more mobile. They got themselves into kind of a dangerous situation, but they had enough standing endurance that the staff could address it. And that's, again, a single case, but I think, was that sort of your question?
Yeah, and just another question. In terms of the mid-loss ADL, was that the group that you would focus on, or?
It's the group that we focused on in this particular study, just because it was a fairly solid thing to address. So transfers and locomotion is a fairly common theme for almost anybody in long-term care. And it's I guess as I was responding to Ibo's question, a way to kind of have a big effect with a single intervention. So if you can address those mid-loss skills, that ability to transfer and the ability for locomotion, you can reach kind of quite a few other different abilities. You can focus on almost any aspect of physical activity, but we found that focusing on the mid-loss ADL skills was kind of the easiest way to have an impact on several different health indicators at the same time, because so many things flow from that ability to transfer and to move. But it could have just as easily been, and we've done projects since, of working on bed mobility, for example, the ability to turn, and specifically outcomes for pressure ulcers. So taking those residents who are kind of most vulnerable, most at risk of pressure ulcers, and just focusing on one aspect of bed mobility. So we have done that as well, but it's a bit more of a specific intervention and not quite as far-reaching as that mid-loss ADL focus.
One final question then. When you are working with homes, is this sort of an additional service or something that's done based on the sort of staffing that's in the home?
So I work with the homes privately, so it is done as a consulting service. So what we'll do is we'll work with, because at NeuroGym as a clinic, we've developed kind of an approach to mobility training, and we'll consult with the physiotherapy provider and the on-site staff in terms of bringing to them whatever we know about mobility training, kind of working with them in that direction.
Okay, thank you very much.
Thank you.
So I don't see any questions online. Is there anybody else on the phone who has any questions? If not, I guess this brings the session to a close, and thanks everybody for participating. Have a good holiday season, and we'll talk again in the new year, and thanks again, Eric.
Yeah, thank you. Thanks, everyone.